So, without further ado, Dr. Omalan Suk.
Good morning. Can you show the presentation, please? On the program is the second one. Okay. I want to thank SAGES and IPEC for the invitation to participate in this debate. I have nothing to disclose. For the surgical treatment of achalasia, we only need the diagnosis of the achalasia. That will be enough to decide the surgery. As you know, achalasia is the most common esophageal motor disorder with a prevalence in adult patients of more than 10 per 100,000 people. And achalasia have an incidence of 0.03 to 1 case per 100,000 people per year. There are three components, as you probably know, in the pathophysiology of the achalasia. And the goal with the diagnosis of this pathology is to demonstrate the presence of these three elements. We can talk about the failure of one of them is the failure of the lower esophageal sphincter relaxation. The second one is the aperistalsis of the body of the esophagus. And the last one is the increased basal pressure of the lower esophageal sphincter. The diagnosis of achalasia is based on demonstrating the impaired esophagogastric junction relaxation, the aperistalsis of the body of the esophagus, and the most specific way to demonstrate this is with manometry. Actually, we can do in two ways, with the classic manometry and the high-resolution manometry. This is a typical tracing of a classic manometry with a water perfusion system. This is probably the oldest system, but the idea here is to show that we can get enough information from this type of manometry that we get from the high-resolution manometry. And here you have this is the normal tracing that we see when we do a manometry in a patient in a normal patient. With the conventional manometry, we don't really have a classification, but we can mention the elements that we want to see in the manometry to define the achalasia, and they are the same that I already mentioned. The only difference that we can do in this classification is the presence of vigorous achalasia, because usually achalasia has low amplitude wave, but there are some patients with high amplitude contraction, and that are the patients that we call as a vigorous achalasia. In this graph we can see what we get in a classic water perfusion manometry in a patient with achalasia. This is the picture of the lower esophageal sphincter pressure that show a high pressure and a lack of relaxation at the lower esophageal sphincter. And this is what we get at the body of the esophagus, where we don't see any peristalsis. Again, this is the picture of the body of the esophagus in a patient with achalasia, where we see the simultaneous wave and where we don't see any peristalsis. This is the typical picture of a high-resolution manometry on a normal patient, where we can see the peristalsis and we can see the relaxation of the lower esophageal sphincter. With this type of manometry, with a high-resolution manometry, we came with a classification in 3 types. One is the classic achalasia. The second one is the achalasia with compartmentalized paraesophageal pressurization that usually have more than 30 millimeters of mercury. Type 3 achalasia, where...
Comment, JP?
So I'm not very good at colors. Todd knows I'm colorblind, and I look at high-resolution manometry. It looks a lot like a weather report to me. I'm not very good at it. I will say that the test that I like to look at most is someone operating on achalasia. I like a timed barium swallow. I like to see that it doesn't empty and what the peristalsis looks like. The barium swallow lets me see if there's vigorous achalasia, if there's nutcracker esophagus, if there's jackhammer esophagus. The pressures are very important, but the configuration of the esophagus is very important because as a surgeon, it lets me know how long a myotomy to make. In achalasia, in classical achalasia, we only need a short myotomy. We don't need to go all the way up the esophagus. In vigorous achalasia, where we see the squeezing all the way up, or nutcracker esophagus, we need a long myotomy. So I like to do a barium swallow, and I always get the manometry and look at the report, and then I ask for the barium swallow. And there are new types of manometry available, something called EndoFlip. EndoFlip, you put it in, it looks like an hourglass, and it shows you what the distal sphincter looks like, and when it relaxes and when it doesn't, we can use it intraoperatively. I think that's going to be something more visual for those of us that like visual stuff. And finally, you're going to have people in areas that can't get high-resolution manometry, and for those folks who refer to me, I tell them, get a cine fluorography, because the cine will tell you about the peristalsis of that esophagus and what it really does. It's an old test that we don't use enough.
Santi, before we get to you, I want James to make a comment, and then we'll go to Santi, and then we'll go on.
Yes, so the senior Dr. Ponsky kind of took one of my points, but I think I'll make 2 points on high-resolution manometry for which I don't typically use it unless the diagnosis is in question. One is cost.
James, before you go, can you tell us what your experience is in achalasia? How much achalasia are you doing?
Right, so we see a reasonable amount as a regional referral center, and we have started doing POEMs at Stanford. We're offering it under an IRB study, as you would imagine, since it's the first pediatric group in the country doing it, I think, in the U.S. anyway. And there has been, worldwide experience in kids, and we're basing all of our work on what the adult surgeons have done in terms of, how we approach it and lengths of myotomies and things that Dr. Ponsky was speaking about. But in terms of high-resolution manometry, I think, cost is an issue. The catheters are about $8,000 to $9,000 per catheter. They are reusable, but cost is seriously an issue. I do think that, as Dr. Ponsky said, if you can tailor your myotomy, I think that's still in question, then that may be an important thing. But my argument against HRM is that you can't use it intraoperatively. And intraoperatively, I have been using, which I'll show later in a presentation, the endoluminal functional imaging system, or the FLIP system. And what that allows you to do is see diameter, pressure. It allows you to see the relaxation of the wall of the esophagus, which I think are going to be important endpoints that we're going to operate to in the future with achalasia. And in addition, they've recently been able to take the peristaltic waves that catheter can measure and turn it into essentially an HRM image. So during the operation, pre and post, you can actually see HRM type imaging. And I think that will be the future from the surgical perspective of achalasia, is being able to see what you're doing in real time.
Perfect.
Thank you.
Thanks. Hold on, don't leave yet. Santi?
Yes, I am also colorblinded, like Professor Ponsky, so we have something in common. I like that. And I feel the same way about the high-resolution manometry. But I am lucky to have Ravi Mittal, who's one of the world experts on manometry, and he's doing a lot of high resolution. The benefit I see is that they are finding a lot of early achalasias patients. So it's a disease that it was not identified with water perfusion manometry. So I'm getting a lot more patients. So if we get more patients, more RVUs, in this moment is time. It's good. So I don't care about the cost of the manometry if I get more surgeries. So I like that. And I will challenge that.
And just one other quick point on in terms of the importance of pediatric surgery being involved with all the high-resolution manometry and/or functional imaging. What we found in our early experience is that the endpoints are a little bit different in our age group, in the 13 to 16-year-olds that we've done. We just don't see the esophagus distending as much as you see in a 70-year-old that you do an equivalent myotomy. And I think it's important for us to understand those differences through this type of measurement.
Before you step down, the CME has asked me, can you just mention your disclosures and say that they're relevant or not?
Oh, yes, sorry. I have 4 disclosures, which are on another slide. None of them are relevant to this talk, but they'll be on the slide in the next session. I apologize, I don't have them all off the top of my head.
Okay.
Thanks.
Pablo, any comments or no?
No, I agree with Dr. Ponsky, but I think these are complementary studies that we have to do on patients with achalasia. We always do esophagogram in every patient, and we also do an endoscopy. So I think that we have to see the clinic of the patient, the symptom of the patient, the manometry, and the barium swallow, and the endoscopy.
I know. All right, good. Thank you guys very much.
All right, great.